Okay. Thank you, Alia, for coming and agreeing to take part in this video. Tell me about what you wanted to discuss today.
I wanted to discuss asthma today.
Right, and is there anything in particular about asthma? I mean, asthma is a very sort of broad subject. Is there anything in particular that you wanted to discuss?
Particularly what I should do for patients that are recurrently getting acute exacerbations.
Right, okay. Should we talk about some of the guidelines then? I think if we talk about the asthma guidelines, then maybe we can get to the answer that way. Tell me what you know about the guidelines.
Okay. The guidelines start from the age of 2, children up to 2 to 5, and then 5 onwards and adults. And with the children, it's slightly different to the adults. So you start off with the Ventolin inhaler, salbutamol, 2 puffs whenever required, and you add in the steroid inhaler, which is 2 puffs in the morning and evening. Obviously, you check inhaler technique, regular intervals, and so on. Then, if the symptoms aren't controlled, you add in the long-acting salbutamol, beta agonists.
So tell me, which guideline are you referring to here?
I'm not sure. NICE guidelines.
Yeah, NICE guidelines. Okay. So these are the NICE guidelines. Then they've been written up in association with the British Thoracic Society. And I think what you're describing really is the stepwise approach to the management of chronic asthma. Is that right?
That's right. Okay.
So if we sort of go back to step 1, and that's when you mentioned the sort of short-acting beta agonists, isn't it?
Right.
So presumably we're talking about sort of salbutamol, isn't it? Really, tuberculin, salbutamol. And then step 2 is what you described in terms of the steroids. The steroid inhalers. So if we stay at sort of steroid inhalers, when would you go from sort of step 1 to 2? When would you make that, when would you go upwards from step 1 to 2?
If they're needing it maybe more than a couple of times a week, I would then move up to step 2.
Right.
And especially if they're having early morning or night symptoms as well.
Right, okay.
And then move up to step 2.
Sure.
Is that right?
Yeah, that's right, yeah. So, yeah, that's perfectly reasonable. Can you remember sort of doses? What sort of dose would you start? What would you start in step 2, and what sort of doses are you looking at?
For children, I would start about 50 micrograms,
right.
2 puffs in the morning, 2 in the evening.
Right.
Obviously, then work my way up if required, if they're still having symptoms.
Sure, so it's 50 micrograms.
50 micrograms with children, but adults I would start probably at 100.
Okay.
Is that right?
I think my understanding is actually it's 100 for children between 2 to 5 years of age. It's 100.
Is it
100 to 200. So that's either 50 microgram BD or the 100 BD. Obviously, I mean, I would start at 50 microgram twice a day. So I think you're. I know where you were getting at it. Did you mean 50 microgram twice a day?
2 puffs, 50, 2 puffs twice a day.
Okay, well, it's 1 or 2 puffs really. Okay, that's fine. And then when would you go to step 3? I mean, you mentioned long-acting beta agonists.
Beta agonists. I would go to step 3 again if the symptoms aren't controlled with the 2. I would add that the long-acting beta agonists if symptoms are controlled with those 2. Again, early morning symptoms, night symptoms, and activities causing more than a couple of times a week.
Sure, okay. I mean, we are talking about, I mean, I think, are we talking about adults or children now?
I would do the same for children and adults, really. Right,
okay. I mean, what I would do is probably have a look at the guideline again, because I don't think it actually mentions the long-acting in the 2 to 5-year-olds. I think where you would go at step 3 is increasing the steroid dose, or in children, or consider something like montelukast, singulair. So that's where I would go. I think serotype or the long-acting beta agonist is more for sort of adults rather than children. Okay, but I think specifically for children between the ages of 2 to 5, I would really think about something like singulair, and if that isn't controlling the asthma, and we're talking about chronic asthma, what would you do then?
Increase the inhaled steroids.
Okay, and if that doesn't work?
Then I probably more than likely refer, but
Right.
you can give them oral steroids as well at a very low dose.
Sure, okay. Yeah, I mean, I think at that stage, if it didn't work really, I would think about certainly referring. Do you know what sort of maximum oral steroid dose you can give in those aged between 2 and 5?
It's 1 or 2 grams per kg.
Is that for children 2 to 5 years?
Yes, that's
okay.
what I know.
I think it's about 800. I think is the maximum 800 microgram. For
right.
we're talking about children, I think you're confusing it between children and adults. For adults, it would be 2,000 micrograms maximum dose. Although
I'm talking about this oral steroids. What are you talking about?
Oh, right, the inhaled steroids.
Are you talking about inhaled?
Yeah.
I'm talking about the oral steroids that 1 milligrams to 2 milligrams per kg.
Yeah, I mean personally,
as steroid dose.
Sure.
That's for acute exacerbations.
Sure.
I thought you were talking about the oral. That was inhalers.
Okay.
Inhalers. It's 800 micrograms.
For children. Yeah. I think you can obviously give steroids, but I think once you're thinking about once it's got to that sort of stage, certainly they would need a referral to a paediatric respiratory specialist, really. For further management, and that's very rare. It's very rare. I have obviously referred children to the paediatric specialist in that point, but it's not very common. I think the most common sort of picture is children on steroids, really, and Ventolin or short-acting beta agonist. Yeah, okay, that's fine. Are you quite comfortable sort of treating children with chronic asthma?
Yeah.
Yeah. Okay. Good. And if we sort of talk about adults, those are sort of, well, when I say adults, I mean 12 and above, because it's 2 to 5, 5 to 12 the guidelines are, and it's 12 and above. What are the differences between the chronic management of asthma in adults as opposed to those in children?
Okay. With the children, after obviously it's in 2 to 5, you just increase the steroids, as you said, and with 5 to 12, again you add in a beta agonist at step 3, and you would consider Montelukast as well, depending on.
Okay.
And then again, step 4 is increasing the steroids.
Sure. Yeah. So I mean, I think the difference really is, as you say, the long-acting beta agonist starting at step 3. Once you've increased the dose of the inhaled steroid, if that doesn't work, you can then go on to the long-acting beta agonist. Or if that didn't work, you could also consider other drugs like theophylline. That would be there as well. And certainly there's more scope to sort of add prednisolone as a long-term, prednisolone longer term, shall I say, well, not sort of short to sort of medium term, really.
So you wouldn't add Montelukast here?
No, I would.
I
would certainly consider it at some stage, and that's probably a discussion to have with the patients. Giving the patient sort of the pros and cons of each drug. At the end of the day, it's the patient's decision. So yeah, I think sort of the Montelukast would be there as well, but it will just depend on the patient. Yeah, I mean certainly I would consider that before starting sort of a longer term steroids, especially in patients, in adults who have diabetes or other chronic medical conditions. Yeah, certainly. Have you had any problems with sort of patients at all dealing with a sort of chronic asthma patients who've been quite difficult at all?
There are patients that where they keep getting recurrent asthma, acute asthma, and some of them end up going to casualty all the time. And would it be wise to give them a course of steroids to keep at home and antibiotics as well? Or would you?
No, certainly I would certainly do that. I mean, what you could do is give them sort of a rescue course of steroids. As you know, we sort of do that with patients with COPD, giving them some antibiotics and steroids. But I think with patients with asthma, I think they tend to get sort of these exacerbations, which mostly don't really require antibiotics. So certainly I would give them a steroid and advise